Welcome to the series uncovering the latest 2025 American Thyroid Association management guidelines for patients with differentiated thyroid cancer. This is Endo in a Bite, where I break down complex concepts into bite-sized pieces that you can actually remember. Today we will be discussing recommendation 31 to 40. Let's begin. First, when it comes to surveillance, ultrasound remains our preferred method for evaluating the thyroid bed and cervical lymph nodes. If thyroglobulin levels are elevated, imaging should always be performed before we move forward with radioactive iodine therapy. For follow-up, ultrasound at 6 to 12 months is appropriate, with timing guided by recurrence risk. Suspicious nodes less than 10 millimeters may simply be observed, whereas nodes 10 millimeters or larger warrant fine needle aspiration with thyroglobulin washout. And when thyroglobulin is rising in the absence of demonstrable disease, consider CT or PET for further evaluation. Now let's talk about radioactive iodine ablation. It is not routine in low-risk differentiated thyroid cancer. However, it may be considered in patients with low intermediate or intermediate to high-risk features. It is standard in American Thyroid Association high-risk patients, and it is also routine in cases of differentiated thyroid cancer with distant metastases. We should acknowledge the limited outcome data in oncocytic thyroid carcinoma. The utility of radioactive iodine in this setting is uncertain. If radioactive iodine is not given, one option is to test for iodine avidity. A diagnostic whole-body scan can also help inform the decision-making process. Moving on to preparation for radioactive iodine therapy, recombinant TSH is preferred for preparation. This is preferred over hormone withdrawal. It's especially important for patients who cannot tolerate withdrawal. If levothyroxine is withdrawn, we should substitute liothyronine and then discontinue it before radioactive iodine administration. Our target is a TSH greater than 30 milli-international units per liter, and in the setting of metastases, either preparation method, recombinant stimulation, or withdrawal is considered acceptable. Dietary preparation is also key. A low iodine diet should be followed for 1 to 2 weeks prior to therapy. This improves radioactive iodine uptake. The principle applies both for ablation and for treatment of disease. Now, regarding imaging, a post-operative diagnostic scan can be performed using iodine 123 or low-dose iodine 131. This is done before therapy to guide treatment planning and refine risk assessment. It helps us determine both the intensity and the extent of therapy needed. After therapy, however, a post-radioactive iodine treatment scan should always be performed. This confirms uptake and documents the extent of disease, providing critical information for guiding subsequent management decisions. If available, we can add SPECT-CT to the whole body scan. This significantly improves anatomic localization of iodine uptake and enhances diagnostic precision both before and after therapy. Equally important are safety measures. Patients must be provided both oral and written instructions before receiving radioactive iodine. This minimizes radiation exposure to family members and the public, and all guidance should be aligned with national regulations. Adequate preparation here ensures safety during treatment. Finally, we must counsel patients on the potential adverse effects of radioactive iodine. It can cause salivary gland dysfunction and lacrimal duct morbidity. Preventive measures such as hydration are recommended. Patients with xerostomia should be referred for preventive dental care, and in some cases, surgical intervention may be required for nasolacrimal obstruction. So to summarize, ultrasound remains central for surveillance. Thyroglobulin trends should guide imaging. Radioactive iodine use is stratified by risk. Preparation must be thoughtful, and both diagnostic and post-therapy scans are invaluable for patient management. At the same time, preventive measures and safety precautions must not be overlooked. Let me repeat this in the form of one-liners. Ultrasound is the first-line method for thyroid bed and lymph node surveillance. Fine needle aspiration is needed for lesions 10 millimeters or larger, or if vital structures are threatened. Use CT or PET if thyroglobulin rises without visible disease. Radioactive iodine is not recommended routinely for low-risk patients. It may be considered an intermediate-risk disease. It is routinely recommended for high-risk patients and for those with distant metastases. The role of radioactive iodine in oncocytic thyroid cancer is unclear. Iodine avidity testing or a whole body scan may be considered if radioactive iodine is not given. Recombinant TSH is preferred for preparation. Levothyroxine withdrawal with liothyronine substitution may be used if needed. The goal for TSH is greater than 30. Either preparation is acceptable in patients with metastases. A low iodine diet for 1 to 2 weeks is recommended prior to radioactive iodine therapy. A diagnostic iodine 123 or low-dose iodine 131 whole body scan may be used to guide treatment planning. A post-radioactive iodine therapy scan should always be performed. If it's available, we can add SPECT CT to the whole body scan for more precise localization of uptake. Patients should receive oral and written radioactive iodine instructions to minimize exposure risk to family members and the public. Finally, we must counsel patients on the potential adverse effects of radioactive iodine. It can cause salivary gland dysfunction and lacrimal duct morbidity. That's it for today's bite-sized episode. Missed a detail? No stress. I've taken the notes for you. Just head over to easyendoprep.com to sign up for the weekly newsletter, and pearls will be delivered straight to your inbox. Remember, stay consistent, and we'll work through all 84 recommendations together, one bite at a time.